So the talk today is about the complexity of PTSD for people living with HIV, and I think you'll see a lot of links between some of the talks that we've recently had in the series on substance use and some of the talks to come, particularly the next one on interpersonal violence. It's a really big topic, so by no means are the slides comprehensive. There's a lot of stuff out there in the literature and in the clinical world that isn't necessarily going to be covered, and that's just because it's such a big topic to sort of whittle down even to an hour and a half that we have. I have nothing to disclose. I'm not being given any money through grants or pharmaceutical companies to be here today. This is sort of our outline, what we're going to go through. We're going to talk a little bit about PTSD because it's such a varied audience. Some of this may be basic for some of you, some of it may be at a higher level for others, but hopefully it will be at a level where we can all sort of go through the content together. We're going to talk a little bit about diagnosis, just touch on kind of physiology behind PTSD. We're going to talk about risk factors because that's a very important part of why somebody ends up sitting in front of us with a diagnosis of PTSD after experiencing trauma. We'll, of course, make the link to HIV and spend a good chunk of time talking about that, and then get into trauma-informed care and treatment modalities, so looking at how we can help treat these patients from a variety of different perspectives. Okay, so diagnosis and physiology. One of the most important things that I want to say is that trauma doesn't equal PTSD. So not everybody who experiences a trauma is going to then end up with a diagnosis of PTSD and seeing one of us in the room. Surveys sort of show us that about 60% of the general population experience at least one criterion A trauma in their lifetime. So that could be any number of traumatic experiences. But that's a majority of the population. And then you compare that to the prevalence of PTSD, which sits closer in the sort of 7, 8, 10% range, depending on what studies you're looking at. It tells us pretty clearly that the number of people actually experiencing trauma is a lot bigger than the number of people who then come to us with a diagnosis of PTSD. Which tells us a little bit that, in certain studies you'll read or people you talk to, PTSD is sort of understood as a disorder of recovery because all of these people experience trauma, and yet only a certain percentage of them end up getting a diagnosis. And then that's where the risk factors really come into play. Who are the most vulnerable? Who are the people that end up suffering as a result of the trauma? When you look at the literature, and some of this is from the US, most common precipitating traumas, so for men, combat, and for women, it's sexual assaults. This data is from the National Comorbidity Survey that's a little outdated now. I think it's from 2000, and it's again a US sample, but the numbers translate pretty well over into the Canadian population, maybe minus some of the combat. But this graph really represents what I've just said, that trauma doesn't equal PTSD, and that there are certain types of trauma that put people more at risk for developing PTSD. So in pink, you'll see the actual trauma, so percentage of the population that actually experienced that type of trauma, and then the yellow is the percentage of those people who then met criteria for PTSD. So you can see rape and combat come out as really the two most common traumas to then lead to a diagnosis of PTSD versus, a 25%-ish of people witnessing a trauma, but then a much smaller percentage of those individuals who then go on to actually meet criteria for PTSD. So one does not equal the other, but obviously related. We're not going to walk through all of the DSM criteria because that's a little boring, and most of you probably know them to a certain extent. Within DSM-5, there were some changes from DSM-4. So PTSD was moved from the anxiety disorders category into its own trauma and stressor-related disorders, with a few other disorders in there. They shifted around the criteria a little bit. They removed from the criterion A the fact that the trauma had to be accompanied by a sense of fear, hopelessness, and terror, fear, hopelessness, and something. There were three things that the person had to have experienced with the trauma in order to meet criterion A. They got rid of that in DSM-5, thinking that those weren't actually very helpful predictors in terms of who might end up with a diagnosis of PTSD. But there's essentially 20 symptoms or 20 criteria that somebody may experience, and any combination of those can end up with a diagnosis of PTSD. So it's a heterogeneous diagnosis. No two people look the same, as with all of the illnesses we treat. So we'll just sort of walk through the different clusters of symptoms so that we have a good understanding of what different things to look for in patients that we see. So of course you have to have had exposure to trauma. That can be either experiencing the trauma yourself or witnessing a trauma. There's also part of the criteria that say, you've either witnessed the event itself or aversive details of the event. And this is meant to sort of capture first responders. So for example, police officers or fire people, firewomen, firefighters, cold brain, showing up at a scene of an accident and there's, body parts or blood or dead people. They haven't actually witnessed the accident happen, but they've witnessed the aftermath. So they might also meet that criterion A if they've seen sort of pieces of the event. The intrusion symptoms are important. So people have to have some element of re-experiencing, whether that's nightmares, whether that's flashbacks, which are conceptualized as sort of dissociative experiences, so out of body, out of mind, where the world around you might not feel real, you might not feel real. People will describe sometimes very vividly being back in the moment of the trauma and smelling and feeling and hearing things that they experienced then. But they can also experience physiological reactions, so heart racing, feeling short of breath, for example, and psychological distress in response to triggers. Those triggers can be external, so people, places that remind you of the trauma, or they can be internal, so actual memories, thoughts, feelings that remind you of the trauma. But there has to be some level of intrusion symptoms. There also has to be avoidance, and that can be avoidance of either internal or external triggers. And of course, this is very specific to whatever trauma the individual experienced. So you'll hear people talk about, feeling distressed or feeling dysregulated when they hear a couple fighting, if they have a history of, maybe physical abuse in childhood or a lot of witnessed spousal abuse as a child. So the avoidance is in keeping with what they experienced within their trauma. The next section is where things can become a little bit difficult because there's a lot of overlap with other disorders that we diagnose and treat. So it's the negative alterations in cognitive mood, and this can be made up of a variety of different symptoms. People can describe amnestic periods for either sections of the trauma or the entire trauma itself sometimes, maybe only remembering little bits here and there. People can describe almost cognitive distortions, persistent negative beliefs about themselves, the world around them. This can be accompanied with a lot of shame, self-doubt, guilt. And then people can have some of the other symptoms that we see within mood disorders, anhedonia, social isolation, the detachment that we can see with depression. The E criteria is alterations in arousal, and so this is really linked to some of the physiological changes that can happen with trauma. So people will describe hypervigilance, they can describe feeling more easily startled. The hypervigilance came up a lot in the female veteran population that I worked with in San Francisco. So for PTSD, the disturbance has to be present for greater than 1 month. And we'll talk a little bit about acute stress disorder on the next slide. But you have to have had symptoms for at least 1 month to meet criteria. And for all of the diagnoses that we treat within the DSM, there has to be some level of distress or functional impairment. Otherwise, people may have symptoms of PTSD but may not actually meet criteria for PTSD. And lastly, just like with all of the disorders we treat, the symptoms can't be secondary to substances alone or to another medical condition. DSM-5 didn't like general medical condition, now we call them another medical condition. So this slide just sort of shows the link with acute stress disorder. So you'll see trauma happens if there are symptoms of PTSD, and acute stress disorder is really sort of a cluster of all of the different PTSD symptoms. If those are experienced within the first month, 3 days to 1 month after trauma, somebody could meet criteria for ASD. It came in to the DSM, I think DSM-4, and there was some concern around this diagnosis, people worrying that it would be over-pathologizing people who experienced trauma and had maybe normative reactions to something horrific that they experienced or witnessed. But the sort of counter-argument to that was it might actually allow for some interesting longitudinal research in terms of identifying people who meet criteria for ASD, who's most likely to then end up getting a diagnosis of PTSD, and what are some of the factors that make an individual vulnerable in that first month. So it's still in DSM-5, although in DSM-4 there was a greater emphasis on dissociation, in DSM-5 not so much. And the emphasis on the dissociative symptoms was mostly acknowledging the fact that if somebody is kind of out of touch with their emotions, out of touch with the experience of trauma, they may not actually be processing the emotions of what happened, and then that can then later build up to come out in symptoms of PTSD later. DSM-5 also has a specifier. So if somebody experiences a trauma, has no symptoms for 6 months, and then starts having symptoms, then they get with delayed expression. There's also a specifier of with dissociative symptoms, and this is for people who experience quite significant derealization, depersonalization. So that's sort of the diagnosis in a nutshell as per DSM. If we talk a little bit about differential, we look through those symptoms and you realize, well, I see a lot of patients where they have symptoms that sound like those, but they don't have PTSD. They have all kinds of other things, or maybe comorbid something and PTSD. What comes to the top of your mind in folks who you regularly see? What's on that differential when you see somebody and you're questioning PTSD?
I was going to just say adjustment disorder.
Yeah, adjustment disorder, for sure. What else? Any thoughts? Shout them out.
Anxiety?
Yeah, for sure. Anxiety. Yeah, absolutely. Especially if you have someone coming in and they're describing like panicky symptoms or agoraphobia, not wanting to leave the house. Definitely. Any other thoughts? Oh, okay. So it can be vast, right? I mean, substance use, borderline personality disorder. We see folks often who have extensive trauma histories. They can present with dissociative type symptoms, impulsive type behavior. Some of that can feel like PTSD. There's overlap with depression, with anxiety disorders. So there's actually quite a broad differential that when we have somebody sitting in front of us and they're giving us this extensive history of trauma, that we need to be sort of thinking about all of the potential different things that this person might also be experiencing. And we know from comorbidity studies, and this is again from the NCS study, PTSD is highly comorbid with a lot of other Axis 1 doesn't exist anymore, but Axis 1 conditions that we see and treat. So this is teased out men and women, but you'll see a major depressive episode. Upwards of 50% of people who have PTSD also meet criteria for an MDE. And then particularly in the male population, you see substance abuse and alcohol abuse come out as highly prevalent. Oftentimes when you hear the narrative, it's to sort of self-medicate the symptoms of PTSD, but they end up sort of leaning into sort of this abuse dependence pattern where the drug or the alcohol becomes almost as much or more of a problem than the actual underlying PTSD. The physiology and, can you see that? Yeah, a little. And this is sort of the basics. But if we look at the system within our body, the HPA axis is very important, the hypothalamus, pituitary, adrenal axis. So when we see stress in our environment, we're walking in the desert and we see a lion. Are lions in the desert? Whatever. We see something scary. Our body reacts, right? Cortisol levels shoot up. All of these different brain areas in our brain light up. We recognize that this is something to be scared of, and we want our body to physiologically respond to that. Fight or flight instincts kick in. So this sort of HPA process happens. Cortisol gets released from our adrenal glands, which sit just above the kidneys. And cortisol is a hormone that really allows us to be agile and adaptive. It shuts down other parts of our body so that we can function in a fight or flight situation. So it actually dampens the immune system. It dampens other processes that aren't as important in that moment where you're trying to get away from whatever's frightening in front of you. With acute stress, the cortisol levels shoot up because we want our body to react. With chronic stress or chronic exposure to trauma, we actually see this hypocortisol state, which then has all kinds of negative sequelae for different physiological functionings within our body, including with our immune system, which becomes very important when we look at an HIV population. Certain brain areas that are particularly involved in PTSD, and there's been a lot of research that's been done in this area. So the amygdala is a very primitive area of the brain that's involved in our detection of fear in the environment. The thalamus is sort of a communication center. The anterior cingulate gyrus, this is an area of the brain that's very involved in emotion regulation and autonomic function, so heart rate, blood pressure, all of these things that are really important when we're, running from the lion or running from something very scary to us. This slide is sort of highlighting some of what I've already said, but really kind of outlining from a neuroendocrine, neurochemical, neuroanatomic standpoint, what are some of the changes that we see in the body after somebody has experienced trauma. Some of these changes are more profound when somebody has experienced repeated trauma, but we can see that hypocortisol state, the CRH, the corticotropin-releasing hormone, is involved in that process of releasing cortisol, and it can actually cause hippocampal atrophy. The hippocampus is a part of our brain that's really involved in memory, so it helps us encode memories and then retrieve them later. So if there's changes to this anatomical structure, you can understand why people would have either amnesia related to a trauma or difficulties then retrieving memories later on or having intrusive memories resulting from the trauma. We see changes in neurotransmitters that we know are important for a lot of the different disorders that we treat. So we see upregulation of dopamine, of norepinephrine, and of glutamate. And these are all excitatory neurotransmitters. So these make people feel more vigilant, more hyper-aroused, with an easier startle reflex because people sort of feel physically more on edge. We see a downregulation of serotonin and GABA. These are inhibitory neurons. So this sort of interferes with our body's own anxiolytic system, what allows us to stay calm and keep calm in moments of stress. And then we see, as I talked about, some of these change in the neuroanatomy that really interferes with our ability to discriminate threat. So when there's changes to the amygdala, changes to the hippocampus, we might see something really benign in our environment and we misinterpret it as a threat. Or we might have a threat right in front of us and we misinterpret it as benign. So it interferes with that discrimination. So we talked about trauma doesn't equal PTSD. So then this sort of leads to the question, well, why? Why does that, 8 to 10% of the population who have PTSD, why are they the ones who show up in our office compared to the 60% of people who have experienced some of the same traumas as that group? What I want to do is, as a group, kind of brainstorm, what are some of the risk factors? What makes somebody vulnerable to developing PTSD? You'll see people sort of categorize risk factors in different ways. One way that I often do it with patients is biological, psychological, social risk factors, kind of teasing out the full spectrum of what's happening at a body level, a mind level, the world around them level. The other way with trauma that's sometimes helpful to tease things out is pre-trauma, what put this person at risk, peri-trauma, what about the trauma itself puts them at risk, and then post-trauma, what was there or not there that then led to a diagnosis of PTSD. The next two slides are really sort of some of my thoughts and pulled from the literature of, the pre-trauma, peri-trauma, post-trauma, and then it's just organized in a different way, biological, psychological, social. But you really pulled out some of the most important things. So that biological predisposition that you mentioned isn't on mine, but should be there. And it's very linked, I think, to the family history in terms of genetics, and that, of course, is then linked to the nurture side of things and attachment and coping and self-soothing and all of that. Females tend to be more, females tend to be, PTSD tends to be more prevalent in a female population versus a male population. The peri-trauma, so some of the things that do come up in the literature and that we see in our clinical experience, trauma that's more violent, if it's degrading, if it's protracted or repeated, and that sort of speaks to the lack of control. Who said that? Did you say that? Yeah, exactly, and that, I think, sort of speaks to that lack of power, lack of control in the situation. And then post-trauma, right? We touched on the poor social supports, the access to service, to treatment. So it's pretty clear that we can, from this list kind of capture, well, who would be at most most at risk for then developing PTSD. It's probably not the people who have stronger, secure attachments, who have good coping styles, who have a number of supports in place, who don't have psychiatric comorbidities, who are kind of biologically non-predisposed. I mean, when you review that list, it feels like everybody should then end up with PTSD. But some people have more reserve than others in terms of coping with it. So then this is just, oh, that shrunk down. This is just sort of organizing things a little differently. And I think it's a helpful thing to do, actually, when you're considering the patient sitting in front of you, trying to understand on your own, and maybe even having the discussion with them, what are the things that put you at risk? Why are you sitting here compared to someone else who has experienced that same trauma but is not in my office? And it helps us kind of understand the narrative of this person's life, and that can become very helpful when we get into more psychotherapeutic sort of strategies to help them get through the trauma. So now we're going to talk a little bit more about PTSD and HIV, of course, and very connected, obviously sort of relevant to why we're here. Very interesting. So there's not great Canadian studies, so forgive the US data. There's a few studies that have been done in the US that have actually looked at prevalence of PTSD in HIV positive versus HIV negative population. Estimates sort of sit around 30 to 50%. There was one meta-analysis that looked at numbers in a female population, and it hovered around 30%. Either way, when we compare that to the prevalence in the general population, we see that the folks that we see who are HIV positive are at kind of almost 3 to 5 times greater chance of having PTSD compared to the average non-HIV positive person. So this is an at-risk group for all kinds of different reasons. Over the next sort of slides, I've kind of organized things similar to how we talked about risk factors, sort of pre-HIV, what puts some of the patients that we see at risk for then becoming infected. During the diagnosis, how does that function as a trauma and lead to potentially PTSD? And then after somebody actually has a diagnosis of HIV and PTSD, what's the interplay there? So that's kind of how we're going to look at things. So pre-HIV, we have to look at much of what you're talking about with the sort of the attachment style. So we if you consider kids growing up in violent homes, neglectful homes, scary homes, these are kids who fail to develop a secure attachment, meaning that they have grown up without a caregiver or a parent who have provided consistent, loving, protection, nurturing, safety when kids need it the most. So these kids then grow up and they go out into the world, and naturally they kind of assume that the world is a scary place and that people may hurt them. People will most likely hurt them because the folks who were actually supposed to protect them and care for them when they were young were the ones who were actually being violent. So this can lead to insecure attachment styles, which make relationships very difficult. This can impair somebody's ability to actually build trust, which becomes really tough for us when we're trying to build a rapport and move forward with treatment in somebody who's kind of marginally engaged with us. The childhood trauma, specifically if it's kind of physical, sexual in nature, can lead to difficulties with self-image, including body image. And really this whole cluster of sort of problems that emerge from somebody being, just a little one can lead to re-victimization, re-traumatization. So this actually puts people then at risk for alcohol, substance use, which can lead to risky sexual behavior. It puts people at risk for impulsive behavior, which can lead to risky sexual behavior. It puts people at risk for getting into power dynamics in relationships where they may become more submissive, not being able to negotiate safe sex, and that then also puts people at risk for transmission for HIV. So you can see how before a diagnosis of HIV is even made, somebody with this type of background is already at high risk for then getting into a situation where they could be infected. And this goes hand in hand with IPV, interpersonal violence, domestic abuse. So individuals who have a history of childhood trauma are also at higher risk for getting into a relationship with IPV. And there can be all sorts of circumstances within this context that can put a partner at risk for transmission of HIV. So whether that's direct forced sex, whether it's inability to negotiate condom use, whether it's if somebody does get infected, threatening to disclose status to other people in their life. So it can become this very tricky power dynamic that can lead somebody to be at high risk for actually contracting HIV. So these are some of the ways, before HIV even comes into a person's life, that trauma and PTSD can then put them at risk for transmission of HIV. With adherence, this is really well documented in the depression literature, that depression interferes with adherence to antiretrovirals. It's a problem. We see people's CD4 counts go down, viral loads go up, because they're so apathetic and unable to care for themselves from an HIV standpoint. It's terrible when we see that happen. Now there's more emerging literature that this is probably the case for PTSD as well. So we're seeing lower adherence to ARVs. Some of this could be comorbid depression. Some of that could be comorbid substance. Some of it could be dissociative type symptoms, people sort of losing track of time, forgetting that they're supposed to be taking medications. Some of it could be linked to trust, right? So after somebody's been traumatized, it's very difficult then to build rapport, get them on board taking medications that they need to take with good adherence for them to work. And then we know that PTSD can lead to some other health compromising behaviors. So people, not being as physically active, for example, as they should, or not having as good sort of sleep-wake cycle as they should. So there's a problem there with adherence that we need to kind of better understand, because it becomes a problem when you're trying to keep somebody well from a mental health standpoint, but also from an HIV standpoint. There's also some question about the physiological effects of trauma. So we talked a little bit about these chronic changes that we see in the body, and there are clear links between cortisol, the HPA axis, and the immune system. So is it possible that individuals who have, you guys have already touched on some of this sort of within the assessment itself. So we talked about the repeated assessments to build trust, making sure that we're paying attention to our mental status exams. So if there's some symptoms or content that the person doesn't want to talk to us about, what can we observe? I can observe hypervigilance. I can observe when somebody's easily startled or when they're sort of emotionally dysregulated in front of me. That's all stuff that I don't actually need them to share with me. I can see it in front of me. So being aware of what we can see, providing choices, right? These are the medications that I'm thinking of. What do you think? Do you want to take some time to read up on them? If we had to choose between these two, which one do you want to take? So allowing them to sort of be part of the process and feel like they actually have control over what's happening. And screening can be a really important thing. So this is less important in the mental health setting because we're typically asking the questions and doing our diagnostic screens. This is more in the sort of family physician or infectious disease setting. So the screening can be either PTSD screening, so the PCL, the PTSD checklist. There's a new one for DSM-5, and it's basically the 20 symptom criteria rated, I think, on a 1 to 4 scale. It's self-reported, so patients can do it kind of in the waiting room, for example, and then we score it. But it's an important sort of screener in terms of filtering out who might then need referral to mental health, and also to sort of monitor change over time. And the other really interesting element of screening is within interpersonal violence. And this is very cool because the next speaker in March is actually one of the researchers from Calgary who have been doing a lot of interesting work on interpersonal violence. And so the next talk will be all on that. But one of the studies that came out of the Calgary group, I think in 2009, was about actually implementing IPV screening within the HIV clinic. And they were finding prevalences of like 35% of the patients endorsing current or recent interpersonal violence. So like really high numbers. And their sort of end conclusion was that this should really be part of standard protocol in infectious disease or family physician clinics because the numbers are so high and they're pulling out people who are in need of sort of safety plan. Like high blood pressure or diabetes. It's not weakness, it's not failure. It's a medical condition that requires treatment, and sort of helping them understand the narrative and some of the risk factors that led to the diagnosis can be very therapeutic on its own. We treat comorbidities, of course, so if there's comorbid substance abuse, getting our addictions colleagues involved, like some of the people you've seen in the recent talks, Dr. Guimond or Dr. Lamba from St. Mike's, we often will sort of work with patients together because they can sort of help us manage the addiction side of things so that we can manage the PTSD side of things. From a medication standpoint, just very briefly, there's no clear indication for treatment of acute stress disorder with medications that I prescribe. Some of the more common ones that we use to treat PTSD are the SSRIs, selective serotonin reuptake inhibitors. So these are like the Prozac, Paxil, Zoloft, some of those names might be familiar. Those are really considered first line for PTSD, not for ASD. There's some evidence for low-dose antipsychotics. Prazosin is used a lot in the US in the veteran population for nightmares and hypervigilance. There's some concern that anxiolytics, so the benzodiazepines like the diazepam, lorazepam, clonazepams, can actually make symptoms worse because they can contribute to dissociation. And then there are a lot of HIV considerations for the prescribing that we do. So there's a lot of interactions that can happen on a metabolic level in the liver. So for example, if somebody was taking ritonavir, we would need to be cautious in terms of our dosing because ritonavir can increase the dose level of medications that we prescribe. So it's very relevant what antiretroviral somebody is on. And then we also have to be aware of antiretrovirals that have psychiatric side effects that can actually look like PTSD symptoms. So with some of the integrase inhibitors, we see sleep disturbance. With a medication like efavirenz, we can see emotional dysregulation. The psychotherapy side of things, so there's good evidence for cognitive processing therapy, CPT, and this is a type of sort of obviously cognitive-based therapy that allows people to process their trauma by building a narrative to really help understand the emotions behind the trauma and some of the guilt and the shame that sort of keeps those symptoms of PTSD as part of their day-to-day life. Prolonged exposure is really for patients who are symptomatically fairly well. You can imagine you don't want to start doing exposure with somebody who is highly symptomatic because you're sort of bound to fail. Exposures are done slowly and in a hierarchical fashion so that you're starting with very small exposures to an element of the trauma and kind of building on that. There's EMDR, which I have no clinical experience with, but it does come up in the literature. And it's basically recall of traumatic events coupled with sort of oscillating eye movements. And it's in the guidelines as a treatment, but it's difficult to sort of find this in a hospital setting. There's DBT adapted for PTSD. There's high comorbidity of PTSD and borderline personality, so DBT can come in as a useful skill. And there's also IPT, which actually isn't trauma specific, but one of the focus areas of IPT is transitions, and diagnoses of illnesses like HIV count as one of the transitions. So I do IPT actually with quite a few of the HIV positive folks who I see in helping them cope with the diagnosis, but not from a trauma perspective. So on that note, here are just some final thoughts. Keeping in mind that the most common response to trauma is distress and recovery. Most people get well after they've experienced trauma. There's a smaller percentage of people, based on all of the risk factors that we talked about, who then end up in one of our offices with symptoms of PTSD. There's a very complicated relationship between HIV and PTSD. So trauma itself can be a risk factor for contracting HIV. HIV can then be a risk factor for going on to meet criteria for PTSD. There are some concerns that PTSD in of itself, much like depression, might actually interfere with antiretroviral adherence and can interfere with obviously CD4 counts, viral loads, and becomes very clinically important as people kind of progress or get unwell from an HIV standpoint because of their mental health symptoms. And lastly, I would just encourage everyone to sort of strive for a trauma-informed approach to care that we provide for patients. Screening is important and asking the question is important. There are treatments that work, but we don't know who to treat if we're not asking the right questions and making the right diagnoses. So I will leave it at that. If there's any last questions, feel free to ask now or come on up. I'll be around for a little bit, but I know we're sort of getting near the end. So thank you for your attention and time. So the talk today is about the complexity of PTSD for people living with HIV, and I think you'll see a lot of links between some of the talks that we've recently had in the series on substance use and some of the talks to come, particularly the next one on interpersonal violence. It's a really big topic, so by no means are the slides comprehensive. There's a lot of stuff out there in the literature and in the clinical world that isn't necessarily going to be covered, and that's just because it's such a big topic to sort of whittle down even to an hour and a half that we have. I have nothing to disclose. I'm not being given any money through grants or pharmaceutical companies to be here today. This is sort of our outline, what we're going to go through. We're going to talk a little bit about PTSD because it's such a varied audience. Some of this may be basic for some of you, some of it may be at a higher level for others, but hopefully it will be at a level where we can all sort of go through the content together. We're going to talk a little bit about diagnosis, just touch on kind of physiology behind PTSD. We're going to talk about risk factors because that's a very important part of why somebody ends up sitting in front of us with a diagnosis of PTSD after experiencing trauma. We'll, of course, make the link to HIV and spend a good chunk of time talking about that, and then get into trauma-informed care and treatment modalities, so looking at how we can help treat these patients from a variety of different perspectives. Okay, so diagnosis and physiology. One of the most important things that I want to say is that trauma doesn't equal PTSD. So not everybody who experiences a trauma is going to then end up with a diagnosis of PTSD and seeing one of us in the room. Surveys sort of show us that about 60% of the general population experience at least one criterion A trauma in their lifetime. So that could be any number of traumatic experiences. But that's a majority of the population. And then you compare that to the prevalence of PTSD, which sits closer in the sort of 7, 8, 10% range, depending on what studies you're looking at. It tells us pretty clearly that the number of people actually experiencing trauma is a lot bigger than the number of people who then come to us with a diagnosis of PTSD. Which tells us a little bit that, in certain studies you'll read or people you talk to, PTSD is sort of understood as a disorder of recovery because all of these people experience trauma and yet only a certain percentage of them end up getting a diagnosis. And then that's where the risk factors really come into play. Who are the most vulnerable? Who are the people that end up suffering as a result of the trauma? When you look at the literature, and some of this is from the US, most common precipitating traumas, so for men, combat, and for women, it's sexual assaults. This data is from the National Comorbidity Survey that's a little outdated now. I think it's from 2000, and it's again a US sample, but the numbers translate pretty well over into the Canadian population, maybe minus some of the combat. But this graph really represents what I've just said, that trauma doesn't equal PTSD, and that there are certain types of trauma that put people more at risk for developing PTSD. So in pink, you'll see the actual trauma, so percentage of the population that actually experienced that type of trauma, and then the yellow is the percentage of those people who then met criteria for PTSD. So you can see rape and combat come out as really the two most common traumas to then lead to a diagnosis of PTSD versus, a 25%-ish of people witnessing a trauma, but then a much smaller percentage of those individuals who then go on to actually meet criteria for PTSD. So one does not equal the other, but obviously related. We're not going to walk through all of the DSM criteria because that's a little boring, and most of you probably know them to a certain extent. Within DSM-5, there were some changes from DSM-4. So PTSD was moved from the anxiety disorders category into its own trauma and stressor-related disorders, with a few other disorders in there. They shifted around the criteria a little bit. They removed from the criterion A the fact that the trauma had to be accompanied by a sense of fear, hopelessness, and terror, fear, hopelessness, and something. And there were 3 things that the person had to have experienced with the trauma in order to meet criterion A. They got rid of that in DSM-5, thinking that those weren't actually very helpful predictors in terms of who might end up with a diagnosis of PTSD. But there's essentially 20 symptoms or 20 criteria that somebody may experience, and any combination of those can end up with a diagnosis of PTSD. So it's a heterogeneous diagnosis. No 2 people look the same, as with all of the illnesses we treat. So we'll just sort of walk through the different clusters of symptoms so that we have a good understanding of what different things to look for in patients that we see. So of course you have to have had exposure to trauma. That can be either experiencing the trauma yourself or witnessing a trauma. There's also part of the criteria that say, you've either witnessed the event itself or aversive details of the event. And this is meant to sort of capture first responders.